to Dr. Ishak Olalere with children. Thank you, Dr. Olalere, for the webinar giver today. So I pass the baton to you. Over to you. Please go ahead with your lecture for today.
Before Olalere starts, we just need to keep some housekeeping rule, which Inikwe will give us briefly. But I want to employ other participants, I mean the participant rather, that if you have any question, please try and drop your question on the Q&A box, not on the chat box. There's a Q&A box, there's a chat box. So let's concentrate on the Q&A box to drop our questions as she goes on with her presentation. So we can have a very unified Q&A session at the end of the day. Anyway, over to you.
Okay, good day, everyone. As rightly mentioned, my name is Uja Samuel Inikpi. I'm a research embryologist, and it's my pleasure to welcome you all to AFRH bi-weekly webinar series, a platform committed to advancing discussion and insights in the field of reproductive health and science. We extend our sincere appreciation to everyone who took time to attend the just concluded 2025 AFRH conference and open house. And of course, we kindly ask for your patience regarding the collection of your certificates. They will be sent to you in due course. The AFRH mobile app, officially launched during the just concluded AFRH conference, is now a permanent feature of our digital ecosystem. I'm sure someone is glad about that. It's actually designed to be, simple, user-friendly, and innovative, and it promises to enhance your interaction with AFRH platform whenever you visit. We encourage you all to follow AFRH on all our social media platforms, the official platform, as displayed on the screen. Over to you, Dr. Akiola. Thank you.
Thank you so much, Dr. Onu and Mrs. Uja Samuel. Okay, Dr. Lalere, over to you, please.
Good afternoon, everyone. Thank you, Dr. Akiola, for the introduction. My name is Dr. Lalere, as earlier introduced. I'll be taking us through the topics that we are all familiar with, which is a recurrent implantation failure, the causes, management, and preventions. We just want to rub mind and remind each other of what we know and what we could do better. So we will be talking on unraveling the complexities of implantation, unraveling the complexity of implantation for better IVF outcomes, using the following outline. So by way of introductions, implantation is a crucial initial event in human reproductions, and that depends on the coordinated interaction between the competent embryo and the receptive endometrium. So when we look at the recurrent implantation failure, it is the diagnosis of exclusions. The exact definition has no uniform definitions and no universal consensus on the exact definition of it. Why some people feel that we could define the recurrent implantation failure as the failure to achieve a clinical pregnancy after transferring good quality embryos in at least 3 different IVF cycles, or in total transferring more than 4 top quality embryos in more than 1 IVF cycles. Okay. We have different diagnostic criteria, which depends the quality of the embryo that is transferred, the number of embryo transferred, and the pregnancy, what they use as the definition of the pregnancy. So why traditionally it was initially believed that the patient can be said to have a recurrent implantation failure if she has had more than 3 or more embryo transfer cycles with a good quality embryo, or in total, more than 4 to 6 top quality embryo, and there's no clinical pregnancy to show for it. In modern definitions, we are now looking at any time that you have more than 2 or more field transfer of embryos that are employed, that are genetically normal, that after being confirmed from the pre-implantation genetic test, and you transfer in total more than 2 or 3 euploid blastocysts with no clinical pregnancy, then be thinking that the patient has a recurrent implantation failure. So what's the incidence of these among the couples that are undergoing IVF? We have about 10 to 15% of couples undergoing IVF that did not have implantations at all, that have implantation failure, despite transferring high quality blastocysts. However, we know that in the most IVF centers, it's only 30 to 40% of it have a successful implantation rate. That's after transferring high quality embryos. But around 25 to 30% couple experience this repeated implantation failure when all the standard parameters appears normal. And also another thing is that this phenomenon increases with advanced maternal age, particularly due to increased aneuploidy rate as the age advanced. Okay, so what does it mean? That implantation do occurs in 3 stages: appositions, additions, and invasions. So it's considered successful when an intrauterine injection site is seen on ultrasound, or implantations has occurred when the if the pregnancy test is positive with the serum beta HCG done. So what are things that could predispose the patient to recurrent implantation failure? Before we could tag the patient that has recurrent implantation failure, we need to look at the quality of the oocyte that is transferred. So what is the ovarian stimulation protocols that was used? Is it optimal one? The cultural conditions that the embryos undergone, the quality and the mode of the transfer of the embryo, okay, and also the endometrium that we're going to implant the embryo is, what's the receptivity of that endometrium. So another factors that we look into is the embryonic factors, which may mean that, okay, what is the quality, the chromosomal abnormalities in the embryo, what's the makeup of the embryo, the genetic defects embryo, is it genetically normal embryo that has a genetical defect are less likely to not to implant. And studies have shown that the majority of them tends to have implantation failure, or even if they implant, they tend to miscarry in the first trimester. So we need to have an insight into the quality of the embryo that is being transferred. Then the maternal factors is equally important, then being that the woman that they're going to carry the age, considering the age of the woman, when you look at the like I said, the advanced age, the effect on the quality of the embryo. Like if you look at it, that the woman oocyte has been formed as far as back as 7 months in utero. This is the quality of the egg that the woman carries around all over, and the as the woman ages, the eggs also age. So this also will have effects on the quality of the oocyte, which will emanate to the quality of embryo that is being produced. So another thing that could result in the recurrent implantation failure is the immunological factors. Okay. immunological factors and hormonal and metabolic factors. We have the male factors, lifestyle, and the environmental factors. We're going to be talking about each of these factors as the presentations goes forward. So I may mention about discuss this one. Then the maternal factors, aside the chronological age of the mother, of the woman, then we have the uterine abnormalities. We need to be sure that the uterus, which contains the endometrium and the myometrium, where the fetus is going to be implanted, has no gross abnormality, vis-a-vis uterine fibroid. Some patients has intramural, intramuscular. Some patients has some endometrial, the fibroid inside the endometrium, that is the mucous fibroid, where the fetus and the embryo is going to be implanted, while some have subserous fibroid. So the locations of the fibroid will determine on its effect on the implantations of the embryo. Yes, I mean, could we say that can fibroid prevent pregnancy from taking place? We cannot. It's not a affirmative statement that you can say once the woman has a fibroid, she cannot get pregnant. A lot of women got pregnant with the fibroid in situ, right? However, some women have submucous fibroid that the implantation taking place on the submucous fibroid itself may just oppose and they refuse to implant properly, or even some may have a clinical pregnancy. By the time the pregnancy is supposed to be progressing, it's definitely miscarry spontaneously. Then another thing that could affect it is that has to do with the morphological, the gross morphology, is the congenital anomalies such that your septate uterus. All this can disrupt the implantations. Some women also have adenomyosis or endometriosis, which they all have their own effect, how they disrupt the implantations. Then in terms of the endometrial receptivity issues, okay, there could be there's something we call the window of implantations, okay, which usually between the day, which varies, okay, in some women from 17 to 19 of the cycle. However, if in the patient that has a recurrent implantation failure, they will notice that there has been displaced implantation window, and this could, if embryo is not transferred at the appropriate timing of this implantation window, the patient may end up not having the appropriate, not having implantations. Then another issue with the endometrium is the endometrial lining, thinning of the endometrial lining, the refractive endometrium. If the endometrium thickness as at the time of the transfer of the embryo is less than 7 millimeter, okay, study that shows the success rate of that implantation tends to be low, okay. And also, in terms of infectivity, infection or inflammation, chronic endometritis tends to have its own effect on the chronic endometritis. Persistent low-grade inflammation of the endometrial lining may have its effect on implantations. Okay. Now, another factors that we're looking at is the immunological factors. Okay. The excessive natural killer cells activity may create an hostile environment for the implantations to take place. And some women have autoimmune conditions like antiphospholipid syndrome, which increase the clotting and tends to reduce the chances of the embryo being implanted. Okay. Okay. So it's a summary. I'll talk about the maternal factors, such as the anatomical defect that could impair the implantation, such as the deformity, septate, fibroid, endometritis, and the adenomyosis. Then the immunological phenotypophilia. So if the woman has the, you need to search and check and be sure that the woman does not have all this before the IVF and the embryo transfer. So in that kind of a situation, a woman that has an anatomical issue like fibroids, we need to have a mammectomy done, either hysteroscopic mammectomy, hysteroscopically or laparoscopically, depends on the size and the number of the fibroid nodule that is found. Some women may have an endometrial polyp, and this also needed to be removed before we go and do the repeat embryo transfer. Then for endometrial growth, there is need for us to look at if there is a patient that has endometrial thickness less than 7 mm, needed to have some interventions done prior the embryo transfer before we could say that the patient has implantation failure. So as regards the thrombophilia, it is I wouldn't say it's not common in this environment. It is because we are not actually investigate it in most of our patients. However, we need to work alongside with the rheumatologists that assess some antiphospholipid antibodies and some other TFR cells and to interleukins 10, interleukin 4, CD4, and all those other TFR2 cells, and to be able to ensure that, okay, this is one the patient has. They have different kind of investigations that are done, and they have the different medications that prescribed for the patient that has such. Okay, and also some of the patients are either placed on the low molecular weight heparin. They know that they have any issues that as related to thrombophilia. They placed on low molecular heparin, or some are placed on the hydroxychloroquine also. But basically, recurrent implantation failure is a multidisciplinary. So when we have the patient that has that, we co-manage them with the rheumatologists that go in depth of the immunological aspects. Then also the genetics. Okay, some patients may have to have the karyotyping done so as to know what exactly, whether there's any balanced whether there is they have a balanced translocation, the translocational issues. Okay, then for the chronic endometritis, we usually place them on antibiotics to ensure that the endometrium is healthy before we go ahead and do the transfer of the embryo. Okay, so there are different investigation workup that is done, investigations that are done for people that have the recurrent implantation failure, like I said earlier. Okay, so for the uterine assessment, transvaginal ultrasound is done to check what is whether the patient has uterine fibroid and other issues that I mentioned earlier. Saline infusion sonogram has also been shown to be of importance to know if they have the endometrial polyp. That one we show there. Then 3D scan also has been of importance. However, hysteroscopy is gold standard. It tends to show the inside the endometrial cavity to know if there is any underlying pathology that is not seen on the transvaginal scan and the saline sonogram. Now, the hormonal and metabolic factors that has been shown to actually affect is also the thyroid dysfunctions has been also shown to have its own effect on the implantation failure. The patients have thyroid function test done, then the serum prolactin, that's a patient that has hyperprolactinemia, then the diabetic, the blood sugar level also need to be assessed. The glycosylated hemoglobin is used to assess the 3 months glucose control of the patient. In some cases, they may have to do fasting blood insulin to know some that have insulin resistance and its effects on the implantations. Then luteal support is assessed by doing the serum progesterone. Okay. Okay. I made mention of all of this. This is this image the image on with my cursor shows the cystic degenerative adenomyosis that looks like the patient has ectopic pregnancy. However, this is adenomyosis, so it also has its own effect on implantation. So for this patient, this is the for patient that presents like this, that's cystic adenomyosis. If we do hysteroscopy, we will have the hysteroscopic view. We have a bulge on the inside in the endometrial cavity, which when it is that bulging is busted, you see image like this showing the chocolatic substance that is accumulated in that endometriotic endometriosis will be busted. And also this make the patient, the endometrial cavity has different indentations that is disrupted from the adenomyotic effect. And with this, it can actually impair the implantations that the patients may have. So another thing that we commonly overlook is the patient that has hydrosalpinx. Also, this is the HSG that shows the patient with the hydrosalpinx. Okay, we could see where this my cursor is, the bulginess of the dilated tubes that shows that the patient has hydrosalpinx, and this is the image transvaginal scan of this the patient that has the hydrosalpinx. So hydrosalpinx is fluid that shows to be embryotoxic. That even if there's any plan for apposition before implantation at all, it will have its effects in disrupting the ideal implantations from taking place. So the patient with hydrosalpinx has to be sorted before we do the embryo transfer. So as regards the male factor, okay, it takes both the good oocyte quality and the sperm, good sperm quality for her to have a good embryo quality. So most of the time we usually overlook the main aspect of infertility. So the patient that has, aside seminal fluid analysis that we usually do, so for a patient that has a recurrent implantation failure, we need to have a searchlight into the male factor, such as aside doing seminal fluid analysis, we have the male to do sperm DNA fragmentations. So that shows that most patients with high sperm DNA fragmentations has effects on the quality of the embryo that is produced and may with resultant recurrent implantation failure. Also, we need to look at the infection, the smoking, the advice the men that have that smokes, that have the varicocele, and the infections may predispose them to the poor quality of the sperm and resultant poor quality of the embryo. So advanced maternal age is also one of the factors that to be looked into, and unhealthy lifestyle like obesity, alcohol, and all sorts of toxins that we consumed from the drugs and the food has to be checked. So all the history of all this has to be taken to us to know where exactly the problem is, since we say that it is a diagnosis of exclusion. So management strategies, like I said, now the definition is going towards saying that we can say it is a implantation failure if the euploid embryo is being transferred. So pre-genetic implantation testing is important, especially for patients that has had more than for patients that have more than 4 implantation failure, or if there is, well, it is a bit on a high side, but it's not as high as the psychological effects and the financial burden of having recurrent implantation failure. So it's advisable for patients to go for it before the transfer, embryo transfer. Okay, and for the patients, for management of recurrent implantation failure, some people also go ahead and especially for patient that has adenomyosis or endometriosis, I would say you ask the patient to do IVF and resolve while the patient goes for the treatment of the pathology or any of these conditions are detected, and before going back for frozen embryo transfer cycle. Okay, and okay, that's some of these treatment or interventions that is being done, that it is not a one-size-fits-all. Some patients, some centers do endometrial scratching and it works for them, while all these our guidelines, American Society of Reproductive Medicine, Canadian guidelines, most of them still feel that it has no it has no contributions to the implantations, why some people do it and it works for them. Okay, some of the patients are placed on the low dose heparin and hydroxychloroquine and the like that I mentioned. And some people, especially those that have immunological pathology detected, are placed on the intralipid infusions. Some have given the intralipid infusions at the rate of 100 mils or 20% solutions IVL for up to the IV for over 1 to 2 hours. And some have shown that the effect of it lasted up for about 9 weeks, and it has worked for them after these intralipid infusions. Some of them actually got pregnancy after following embryo transfer. Okay, so other interventions that has been shown to help patients include the granulocyte CSF that some patients are placed on, and it works for some, like patient that has refractive endometrium, or those that have thin endometrial lining. If they detect that that's one of the problems that resulted to it, some of them have used platelet-rich plasma protein infusions, endometrial infusions prior the embryo transfer, and it works for them. While some actually added that subcutaneous CSF, GCSF to it, or some may have it endometrial infusion of it, and so in some situations it has worked for them. However, there is no consensus that everyone that has it is used for them, is worked for them. For the hysteroscopy, okay, there is this study about the trouble study that shows that why the hysteroscopy has been seen in the limelight of saying the gold standard to investigate the patient that has a recurrent implantation failure, so as to know whether this patient has any underlying uterine pathology. So they did these studies that shows that 24% of women that had undiagnosed uterine pathology, such as these fibroid polyp Asherman's, and they notice that they don't find the improvement in clinical pregnancy or live birth rate of in their studies. However, the study is a biased one and to start with, they say only 4% out of these 24% that were picked to have undiagnosed pathology, and they have recurrent implantation failure were treated. So we're not told why the only 4% out of 24 was treated. So the study is a biased study from my own point of view. However, they said that we cannot generalize that everybody that wants to go for IVF or everybody that has recurrent implantation failure has the have to go do the hysteroscopy. However, it has been of help to a lot of people that have the implantation failure. Okay. So these are the things I tried to mention earlier. The VGT, then in the lab, the AI-based embryo selections are shown to improve the implantation predictions. So as not all the embryo that lose grossly morphologically normal will be actually normal in the sense of it. Then for the AI-based embryo selections has helped to improve the implantation predictions and the implantations at the long run. Then the I mentioned about the PRP and personalized implantation window. Okay. Now, how does the lifestyle management get to help? So for patients that has overweight or obese, they need to lose encouraged to lose weight, healthy lifestyle, exercise. Those that are smokes, they avoid smoking and alcohol, and advanced techniques such as IMSI, intracytoplasmic morphologically selected sperm injections, tends to enhance the sperm selections, and that one has shown to also helps in the implantations failure. Then assisted hatching has its own also effect in improving the patient that has a recurrent implantation failure. Okay. So in what are the preventive measures? Like what we said, they need to optimize the maternal health. Those that are obese need to control the weight. Those that are diabetics need to have a good glycemic control before we say the let's go ahead and to have a repeat embryo transfer. For the thyroid dysfunctions need to be attended to, be sure that the thyroid, they are euthyroid before they go ahead with the embryo transfer. Then they ensure that uterine cavity is normal before the transfer, and also adequate luteal support is important to prevent to enhance the good outcome of pregnancy. Okay. So in conclusion, baseline fertility workup is complete. We ensure that the baseline fertility workup is complete before we tag the patient that it is a implantation failure that it has. Because if there's any pathology that is detected, we need to treat it and ensure that every other thing is out of way. Uterine anatomy, ovarian reserves is intact, ensure the semen is of good quality, there is no hormonal imbalance before we could say that, okay, there is implantation failure. Then also, we using a working threshold, 3 failed transfer of good embryo as a practical red flag. So we need to interpret the embryo quality before we say, oh, we have 3 failed transfer of good embryo. We need to interpret the embryo quality, check the age of the patient, the cumulative prognosis before we say, okay, it is actually implantation failure. So when we are in, we need to be transparent with the patient. Let's carry them along. Interventions, there's no intervention that is one size fits all. Most of these interventions, like the filgrastim, the PRP, and some other things are still under the debate and the decision should be individualized. It's not all the patient that is we give all the interventions to. So it's not one size fits all. So these are my references. Thank you.
Oh, wonderful, wonderful, wonderful. A very well delivered presentation by Dr. Halima Olalere. Thank you very much for doing justice to this topic. It's a very wide and controversial topic, and we cannot, cover it 100% as it were. And from your presentation, you can see that a lot of things are still very controversial. No uniformity in agreement in most of the things. But you have really done justice to this topic that seems a little bit controversial. Looking at definition alone, different portals have come to give different definitions. And at the end of the day, we are just left to, incline on clinical practice to, decide what work best for you. And a lot of consensus trying to come up on ASRM, HRA committee, and the rest. What is recurrent implantation failure? What are the causes? How can we manage them? How can we even diagnose them? So thank you. I will say thank you very much. We go into the Q&A right now. I have a question from the audience here. It says, are there alternative ways of managing recurrent implantation failure with high suspicion of aneuploidy in patients that can't afford PGTA? You get it? Is there any alternative way when you have high suspicion of aneuploidy, if a patient cannot afford PGTA and the patient is not open to donor oocyte, donor gamete IVF, are there alternative way? Hello, Halima.
Well, hello, sir.
Yeah, did you hear that question?
Hello, sir.
Hello,
yes, I heard the question.
Okay.
If the patient is not open, yes. If the patient is not open to PGTA,
to donor gamete,
so
not open to PGTA.
The easiest way I would have said is she go for donor gamete if she's not open to PGTA. However,
but he say it's not open
the
to
patient,
donor gamete.
apart from manipulation, maybe I don't have this. I don't know. Maybe they may need to look at what are the other things that are causing probably the patient needs to be actually investigated to know what are the other things that are causing the
this question is specific. This question is specific that the cause of the recurrent implantation failure is highly suspicious to be due to aneuploidy. And the patient cannot afford, not that it's not open to, cannot afford PGTA, but not open to donor gamete. So, any other option? It's a suicidal question now, Abi.
So if I may come in, Dr.
Yeah, Latif.
Yes, if the patient is not open to all the what you mentioned, is the patient open to adoption? Because if the patient is highly suspicious, as she and then she has the recurrent implantation failure, either she find money, borrow money, go to Access Bank and do PGTA, and PGTA prices are coming down very, very fast. You know, in the past, it used to be like $15,000, but now you can get it even with $2,500. So it's not, it might not be an option if she has tried um, several, she's always having recurrent implantation failure or no pregnancy at all, then the best for her is to gather money and do PGTA, either embryo biopsy or non-invasive. So that's option. If she cannot afford completely or she doesn't want it, then we have to continue to try morphology, morphological assessments of the embryos. Either you are using time lapse, or we can even use artificial intelligence to select our embryos. So all these are options that are open to her. And the last will be adoption. If she doesn't have any,
okay,
she doesn't want
thank you.
she doesn't want I think that's the best way
Thanks,
for her.
Professor Akinola. Yes, sir. So the next question here is, what is the role of hysteroscopic assessment in recurrent implantation failure? Can you unmute yourself? Unmute yourself, Halima. Unmute yourself.
Okay. Hello, sir.
Yeah.
Yeah, like I said, if you see in one of my slides, that hysteroscopy has a great role to play in the assessment of recurrent implantation failure, especially in a patient that has the morphological anatomical issues. Okay, in some years we've had the patient that has been having recurrent why this was recurrent pregnancy. Okay, and after so many attempts, she just came around and they said, okay, why not try for hysteroscopy? And you know what they was found there? Broken the bone, fetal bone of the miscarriage and of the abortion she procured as a young person before she got married. And immediately the bone is removed, she got pregnant spontaneously. So there are some patients too that has a uterine pathology that may not be picked on transvaginal scan, probably before the IVF, that hysteroscopy will pick. So patient that has a septum, hysteroscopy picked it. Patient that has a submucous fibroid, hysteroscopy picked it. At the moment, I have the patient that has presented to me with a recurrent implantation failure. So, and that one also has a issue with the ovarian reserve. So she only came for assessment of ovarian reserve. And when we did the assessment, I was okay, we did the scan that something that looked like one small polyp or thereabouts. We did the stereoscopy. The submucous fibroid that was there. And it's less than 3 months that she just had the IVF done. Okay. So there are some things like that that it is not picked with other ancillary investigation, that hysteroscopy will give you a direct visualization of it, and it may be in one sitting of treatment.
Okay, thank you very much for that answer. The next question is, we've talked about good quality embryo before you can say recurrent implantation failure and stuff. You say, how can one know a good quality embryo?
Okay, I presume the person that is talking is an embryologist, because it's only the embryologist that will be able to tell you that this is a good quality embryo. Okay, so embryos are graded by the embryologist, and we have day 3 embryo, we have day 4, day 5 blastocysts. Okay, so the grading depends on the number of the cells that the patient and the embryo has, and the expansion, the symmetry, inner cell mass, the outer cell mass. So they have the grading for the inner cells is different from the one for outside cells. So we have A, B, but for the number, we have the one that is from 1 to 5. I think we have, at times we have 6, but if you have 5AA, it's a top-notch quality, good quality embryo. But some people still use 5AB for also, but the grading of the embryo is by the embryologist. Thank you.
Okay, thank you. The next question is regarding error test. Could you elaborate on how it determines the personalized window of implantation and how stable that window remains across cycles?
Okay. Error test is the, they call it endometrial receptivity analysis. Okay. It's hard to know the window of implantations, and it's based on the gene activity. So the test classifies the receptive, and post-receptives. So the cycle at which they are going to do the embryo transfer, that's not the cycle they use in error test for. Okay, so when error tests give them the idea of this is the time after the ovulations, that is the time of a good receptivity, then they had 24 hours to that timing. So for them to be able to know that this is the most the time that's the best time to do the embryo transfer.
Okay, thank you. The next question here is, in our environment where IVF is still totally out of pocket, should we still wait for 3 to 4 implantation failures before we diagnose and act?
No, sir. Like, that's why we say that the definition, the diagnosis of recurrent implantation failure, just like the diagnosis of recurrent miscarriage, the new diagnosis now is they don't wait as soon as the patient has lost more than 2. You could see that the slide that I showed initially, it said that the patients that have lost 2 or more implantation, okay, after 2 or more implantations, 2 or more implantation failure, or the transfer of 2 or more, 2 to 3 euploid blastocysts, then the patient needs to be evaluated. You don't need to wait for the patient to have a 4 failed implantation failures before the patient is assessed to know is there any other underlying factors that is predisposing the patient to implantation failure. Thank you, sir.
Okay, yeah, so the next question is, if the prolactin was just at the upper limit of normal while investigating the patient, how should the patient be managed for a possible outcome?
Okay, so there are different things that make the prolactin to be elevated. Okay, so that patient needs to reassess. Okay, then look at what are the lifestyle issues. What are things that the patient is doing that is making the prolactin to be elevated to start with. Okay, some patients may be on some medications that will make the prolactin to be elevated, while some patients may just be fondling or the suckling of the breast by the partner. That is, we know what about the Michelet leg down reflex. Maybe the fondling or the suckling of the breast by the partner that is making the prolactin to be elevated. So those lifestyle modifications have to put check and balance too. And some people may be on some medications such as the antidepressants or some other antipsychotic or thereabouts. So the patient has to look what is that the patient is on to start with that is making that prolactin to be elevated. Okay, so those are things that we look into. Then we now ask the patient to repeat the serum prolactin. Okay, then we look at it that if the prolactin is elevated, does it translate to patient having galactorrhea, with the milk coming out from the breast of the woman? Okay, so all those things are the patients need to be evaluated as a whole, not just picking one test and
all right. Thank you very much. Then it's the question here: endometrial scratching, where does it apply?
Okay, endometrial scratching is okay. Okay, some people normally do it for patients at the prior the cycle that the patient is going to have the IVF cycle. So maybe like the luteal phase of the cycle before the IVF. So what they do is that they usually either they do hysteroscopy, pre-IVF hysteroscopy. They may during the pre-IVF hysteroscopy, they may do endometrial scratching. They usually do endometrial scratching at that time. And some people may not be doing it during the hysteroscopy. They can do the scratching itself without doing the hysteroscopy.
Thank you very much, Dr. Latif. I think I mean that's the last question we have on the panel. But there's a comment from our dear Mr. Ola, you know, that I mean, in anything we do, that we should apply caution, you know, particularly for young patients when they have very good blastocyst, you know, when they have very good blastocyst to be transferred, that PGT might not really be of any good help in terms of, I mean, considering cost and the rest of them, particularly for young patients, you know, that is just bringing a word of caution, you know, for us to just think, ruminate on. Thank you very much, Dr. Latif, over to you. Unmute yourself, please. Unmute yourself, sir. Latif, unmute yourself. Dr. Akiola?
Yes, thank you very much, Dr. Onu, and thank you, Dr. Ladere, for a brilliant presentation. Just my little comment on Dr. Ola's comment that PGTA may not be very helpful in young patients with good blastocysts. Yeah, that is correct. If you look at all the management strategies outlined by Dr. Olalere, most of these are still on trial basis. And using any of these, very, very controversial. I mean, you want to talk about ERA, freeze-all, endometrial scratching, we are all just scratching the space. You know, we are still very, maybe not too far, but we are still far from knowing the real cause of the of recurrent implantation failure if there is no definitive diagnosis by all the imaging, blood tests, immunological tests that we've done. So all these are still very controversial, even including PGTA. And in fact, you might do all your investigations and the patient is normal. So in that case, we give TLC. They call it you give treatment that is has not been proven, and that is not very beneficial to the patient. So Dr. Lalere, we thank you so much. You've gone through all the causes, the definitions, and the treatment investigation. So again, we have to thank you. We thank the audience too for staying up till this moment. I think the AFRH has some announcements. Mrs. Samuel Uja, any announcement from AFRH, please?
Yes, very well, sir. We appreciate everyone for joining our insightful session today with Dr. Halima Olalere. And of course, with respect to the certificates for the just concluded AFRH conference, we deeply value your patience so far as we finalize the process for certificate distribution. Please be assured that they will be sent to you in due course. As earlier mentioned, the AFRH mobile app, which was launched during the recently concluded AFRH conference, is now an integral part of our digital ecosystem. So it's designed to be a simple, user-friendly, and innovative platform. It is built to enhance your interaction with AFRH platform whenever you visit in a very remarkable way. And of course, kindly note that our webinar series is a bi-weekly event. Kindly keep your calendar open every second and fourth Wednesdays to be part of this educative webinar series. So our next webinar series will be on the 22nd of October, 2025. And we encourage you all to please stay connected to AFRH by following us on all our official social media platform. And of course, we trust, right now it's being displayed on the screen, so please do well by following our social media handles. Thank you all for being part of this impactful AFRH webinar series. Together, we continue to advance knowledge and excellence in fertility care. Thank you, everyone.